Hello, good afternoon, good evening, and good morning to everyone joining to our weekly COVID-19 related Q&A session with Dr. Maria van Kerkhove this time. We are in Palais des Nations, where a historic 75th World Health Assembly is taking place. And this is why Dr. Mike Ryan is not able to join us today, because he's in the discussions with our member states. So Maria, thank you for your time. As just said, the historic World Health Assembly is happening this week. Our Director General is re-elected for his second term for another 5 years to lead the organization, including this response to the global emergency of COVID-19. So far, there have been a lot of discussions on emergencies and other topics, but is there anything specific that has been discussed and decided in regards to the ongoing response to COVID-19?
Hi everyone. Thanks, Alex, for having me back on this one for COVID-19. So yes, we are at the WHA, as we call it, the World Health Assembly, and it's the first time that member states have gotten together all together in 3 years since the start of this pandemic. So there's a lot of discussions that are happening, and in fact, everything is live streamed. So if you want to watch what is happening, you can go on our website and you can click on the links and see what's happening in different committees. And it is quite exciting because as the World Health Organization, we work throughout. We're the secretariat of all of our member states. So there are lots of important discussions being had for COVID-19 and many other aspects. With regards to COVID-19, we had a briefing yesterday where we updated the member states on where we are in this global situation, really what we're asking member states to continue to do to enhance. So with regards to decisions, it's really about how we collectively end the emergency of the pandemic. So not really formal decisions about the pandemic itself. There are a lot of discussions that are being had about how we use COVID-19 pandemic for the future and how we are better prepared. But those discussions continue to be had and will take quite some time. And I know we'll do a live Q&A with Mike next week where we will get into more detail about what was discussed and what was decided, because they're still deliberating right now. But what is really important is that we understand that we are still in this pandemic and that there's so much more to do and there's so much more that we can do. And it's about using the tools, public health tools with surveillance and testing to have a better handle on the virus itself, but also use the tools to protect people's lives. And that we mean everywhere, not just in high-income countries and people who are lucky to have access, but everywhere. So lots of really good discussions that are happening in plenary with all of the member states, but also a lot of individual conversations with countries.
Thank you, Maria. And I really hope that in this assembly, member states will also take stronger position on equity, not just vaccine and COVID-19 tools, but health equity in general. I would like to remind our viewers that you can ask your questions to Maria. As usual, if you're watching us on Twitter using the hashtag AskWHO, if you're watching us on other platforms, please leave your questions in the comment section and I will pass it on to Maria. And while we're waiting for the questions from viewers, maybe as usual, Maria, would be good to provide epidemiological update in terms of cases, hotspots, but also mortality rates.
Yeah, so as you know, we published our weekly epidemiologic update. We will continue to do so, as we go through this pandemic, and it's really a rich source of information. In the last 7 days alone, we did see a decline at a global level of cases being reported to WHO, but still more than 3.7 million cases were reported to us in the last 7 days alone. And what's really important about this number is that these are people, of course, first and foremost. And while we do see a reduction in severe disease because population level immunity from past infection and vaccination is increasing, 3.7 million cases were reported in the context of significant reduction in testing. And this significant reduction in testing has been happening over many weeks now. So we do see a decline in the reports of cases, but our confidence in that, our reliance in that, I would say, the reliability of that, I should say, is dwindling. I'm not as confident that those numbers are as firm as they could be because testing rates have dropped. At the same time that testing rates have dropped, we've also seen an increase in self-testing, which is a good thing. So a lot of people have access to these reliable, cheaper, they're still not as cheap as they need to be, self-testing, and that's not always captured in the surveillance systems. So globally, we saw a reduction across all regions with the exception of the Americas, where more than 1 million cases were reported last week, and in the Western Pacific, where almost 1.5 million cases were reported last week. So all of the other regions are reporting a decline. That's cases. Now for deaths, we did see about an 11% reduction in the reported deaths over the last 7 days alone, but still, more than 9,000 people died last week. 9,000 people died from COVID-19 in the context of having tools that save people's lives. This is unacceptable to us. This virus is still causing damage to our societies, and that's why we need to pay attention. We did see a reduction in deaths being reported across most of our regions. We saw about the same amount of deaths reported in the Western Pacific as well as in the Americas, but we saw a 30% increase in deaths in the Eastern Mediterranean region. So it's a mixed picture, as it has been since the beginning. And of course, the global level gives us one snapshot. Regions are very different, nations are very different, and of course the subnational level gives us a different picture there. So it's important that we are able to continue to track this.
Thank you so much, Maria. And you said globally we see decrease in testing. So how worried are you about this?
We are worried about a decrease in testing for a couple of reasons. First, if we reduce the amount of testing, then we lose track of this virus. We lose track of the trends in terms of who is getting infected and whether or not there are changes in the populations of people getting infected, particularly those who are most vulnerable, who have an increased risk of developing severe disease. We have a reduced ability to understand tracking of the variants themselves, because when you have reduced testing, you will have reduced sequencing. And if we reduce our sequencing of this virus, we will not be able to track the changes. Omicron is dominant worldwide. BA.2 is dominant worldwide, but we are seeing increases in the proportion of BA.4 and BA.5, as well as BA.2.12.1. These are sublineages that we have to continue to track. So if we reduce testing, then we will reduce the amount of sequencing. And we do see that actually in the number of sequences that are submitted to platforms like GISAID. And if we don't have those sequences, we aren't able to analyze. We're flying blind. And one of the big things about this particular virus is that we need to be able to track its changes. It's not operating in a predictable fashion. And so public health professionals, scientists around the world are looking at these viruses that are being detected. If we don't have testing, we lose that ability, and that's really concerning. The second reason we're concerned about a reduction in testing is we are seeing some countries defunding testing systems. We're seeing some countries lay off the workforce that are able to test, and this is really short-sighted. We need these systems in place for strong surveillance for COVID, but also for other diseases that are circulating. Monkeypox is a good example. There are other pathogens. Influenza is another pathogen that's a good example. We need these systems strengthened. So we don't want to see countries say, we don't need any more testing and therefore we don't need to fund that anymore. That's not really the right choice right now. We need to continue to test and improve our surveillance, improve our sequencing capacities for this pandemic and for anything else we face.
Speaking of reducing resources, one of our viewers is asking whether countries stop offering vaccination, and I believe that countries did not stop offering vaccination, but probably services are reduced and people are not aware as well as they used to be a couple of months ago where to access the service.
Yeah, I think a lot of things are changing. Given that we're in the third year of this pandemic, we're in a different situation than we were in the beginning. Certainly we are seeing globally a reduction in hospitalization and deaths, and that's because we have access to therapeutics and because we have vaccines. But those vaccines are not reaching everyone everywhere. So it is about access. It's about using these vaccines epidemiologically sound, the right way, but also ethically sound. And we will still continue to fight for equity. But I think you're right. A lot of the services have been stopped and people may not know where to get tested. They may not know where to get vaccinated. We are asking all countries, and when I have had the opportunity to meet with individual countries here on the sidelines of the WHA, this is incredibly valuable to have that one-on-one exchange. We are asking all countries to maintain these systems and to really strengthen these systems for the current crisis as well as into the next. But the emergency at a global level is not over. So who within your country are you missing in terms of vaccination? And who are you missing who's over 60 years old, over 70 years old, over 80 years old and find them. Find why they're not reaching, why they're not getting that full course of doses of vaccines. Who in your at-risk population are you missing and why? And find them. It's not even about, we have the 70% target, which is hugely important as a target, but within that 70% of people in all countries, it's 100% of those at risk. So find who you're missing, find those individuals and make sure that they have access to that vaccine and work through any reasons of hesitancy or any questions that may have, because vaccines still save lives.
Yeah, we got a few questions about the situation in Africa, and one is from Brian Tobin. Are rates of COVID-19 in Africa lower than other countries, or does this represent lack of testing in rural, medically underserved communities?
There's certainly differences in the circulation of this virus around the world, and there's different peaks that are happening. Across Africa, there's the circulation of the Omicron variant as well. We do know that the amount of testing that is happening on the African continent, and the African continent is very big. There are many, many different countries there, very diverse. Each one is unique. We can say for sure that the amount of testing in Africa is very low. And so we're not able to detect, there's probably many unrecognized cases. But if we look at seroprevalence and we look at past infection, missed cases, certainly people have been infected across that continent. So we need to get our testing rates up. We need to provide access to those tests, make sure that they're affordable, that they're reliable, and that testing links to action. And so that people receive the services that they need in terms of clinical care, in terms of the knowledge that they need to keep them and their families safe.
Thank you so much, Maria. Here's a question from Malik Haruna, watching us on LinkedIn. If you consider the epidemic current trend, which age group are more affected, and what are the interventions for this group?
That's it's a very good question. The short answer to that is it depends. Vaccines work incredibly well at preventing severe disease and death. They have since the beginning, and we have many, many vaccines that are available that are preventing severe disease and death. What they don't do perfectly is prevent infection. So we still see, with this virus circulating at such an intense level, we are seeing people get infected. And what we do see in terms of the rates of infection, it happens to be with people who are mixing. So if you're out and about and you're mixing and you're not wearing a mask, you're not distancing, you're not in well-ventilated spaces, the virus will take advantage of that. And so we need to make sure that we use our interventions in a layered approach, and that we work with communities to find the right solutions. I think one of the things we want to be able to do is find tailored solutions for populations. One of the things that happened to me, I think it was last week, is we met the Global Youth Mobilization. They had their board meeting here, and it was so inspiring to listen to them in terms of all of the activities that they've done going into the communities and working with communities and finding solutions. If you remember, Alex, there were a lot of young people blamed for COVID-19 and for the circulation, saying, oh, they just want to go out to parties. And that was unfair, and it was incorrect, in fact. And so working with youth and finding solutions that meet the needs of different populations is really quite inspiring. So it's a long-winded answer. There's no one solution to this, but it's about working with communities to find tailored approaches that work for everyone.
Thank you so much, Maria. Here's a question from Michelle Gigot. I hope I pronounced that right. Please address long COVID, including risk factors, so that people not afraid of mild COVID acute infection can be warned of the real possibility of months or years of suffering and disability.
Yes, so long COVID or post-COVID-19 condition is something that we are very concerned about. This is, we have a definition of this, and typically it's people have longer lasting symptoms 3 months after their acute disease. This is just a definition that we're using for now. We will modify that as we go forward. But post-COVID-19 condition is real. It needs to be recognized, and we need to have a comprehensive approach for dealing with this. We don't have great data on post-COVID-19 condition yet, but many, many people around the world are studying this. We, through our clinical management team, our rehabilitation teams, our mental health teams, our teams that are dealing with many different health effects, like the things affecting the brain health, cardiac care, etc., are trying to work to understand rehabilitation that is needed. But long COVID or post-COVID-19 condition is real. The estimates pre-Omicron were 1 or 2 in 10 individuals who were infected would go on to develop some longer-term effects. But quite frankly, we don't have a clear picture of this yet. So we have been talking about this for a while. Not only is it important to get vaccinated to prevent severe disease and death, we have some studies that suggest getting vaccinated reduces the risk of long COVID, but really we need to prevent infection in the first place. So it still is important that you reduce your opportunities for exposure, even if you have been vaccinated, because there still is a risk for developing long COVID.
Thank you so much, Maria. Speaking of this perception that we are not at risk anymore, Fred and Kirsten, who was watching us on Facebook, says people are getting complacent. What do we tell them? Because there is so many opinions and conspiracy theories.
I think complacency is something to worry about. It is something that I worry about. And especially now, we've been dealing with this pandemic for 2.5 years now. And people are tired of talking about it. People don't want to discuss this anymore, but we have to continue to talk about it, and we have to remain vigilant. You know, we get a lot of questions even now. Why aren't we wearing masks? I've heard some questions about people say, well, we've seen some videos at WHA and people aren't wearing their masks as much. We can't lose sight of that, and we have to make sure that we wear our masks when we can. At certain events like this one, you know, we self-test every day because we're coming back together with many people. We've been vaccinated. And we do wear masks when we're close to one another. But we're asking people to be smart, to be cautious, and we're asking for government policies to be rational. It's not an all or nothing. Make sure that people have access to the vaccines. Make sure that testing is still available. Make sure that there are good policies that if you are sick, you're unwell, and you can work from home, that you are supported in doing so. So all of that really matters, and we just can't lose sight of the pandemic itself. This virus is still causing devastation in our society. It is still impacting our communities. It is still killing people unnecessarily, and so we as WHO will continue to raise awareness about this and make sure that we do everything that we can to keep people safe, keep people healthy, keep people contributing to their economies, and get on with their lives.
Thank you so much, Maria. Speaking as well about complacency, what can we remind viewers in terms of testing? You mentioned there's more access to self-test, so there is more. We have more tools as well on individual level that we can use. So, how people can assess when they can get tested, and also if they don't feel well, what they should do, as we are talking about complacency and going back to normal lives. So a year ago, we were all worried about getting tested, practicing all measures very regularly. So maybe just a reminder. And you also spoke a lot before about the plan in case someone gets infected. So having that individual preparedness plan, what to do in case of infection.
Similar to what we were saying previously, but a reminder, a refresher is good. People have changed over time because they have gotten vaccinated, but we are still recommending that if you're unwell, to work from home or to stay home and to get tested. It depends on where you live, how you can get access to tests. So that's a difficult question for me to answer because a lot of the testing centers have closed. But in many countries, access to self-tests you can pick up at a pharmacy. That is not true everywhere, and these tests are not cheap. I mean, they're much cheaper than PCR-based testing, but in some countries they're exceedingly expensive, and even a test at $1 is expensive around the world. So what we still recommend is if you're unwell to work from home. We are hoping that there are supported policies for people to do so, to keep your distance from others and get yourself a test. And if you do test positive, to isolate. Our recommendations are still in place that if you test positive, to isolate so that you don't pass the virus to someone else, because it's not just about you. If you are vaccinated and lucky to be vaccinated and have the full course of that vaccine, your risk of developing severe disease is much lower. There are also now antivirals. There are therapeutics that are available in some countries. Access and price is also an issue for the antivirals, but we have many opportunities to seek care. So getting a test and getting that test early can get you into the clinical care pathway as well. And then we still recommend contact tracing. However, that becomes very difficult in many places where you have large numbers of cases. So we're asking for contact tracing to be prioritized, particularly in risk groups. So for example, groups that live in residential homes, long-term living facilities, so that we can take the appropriate action. I think the point I want to make, Alex, is that we still have a lot of options to prevent the spread and to reduce severe disease and death. We can't only focus on one arm of that equation of preventing severe disease and death. We also have to take steps to reduce the spread because we have the risk of variants, further virus evolution, and we don't know what the next variant of concern will bring us.
Thank you, Maria. In follow-up to potential new variants, here's a question from Sarah Spurling, also watching us on LinkedIn. What's the latest information from researchers studying the virus? Is there any new information around how the virus is evolving?
There's new information every day. Again, we're so grateful for all of the researchers that are around the world that are testing, that are sequencing, that are analyzing each of these mutations. So as you know, we are tracking the Omicron variant of concern, and several sublineages of Omicron because this virus continues to evolve. By far, BA.2, which is one of the sublineages, is dominant worldwide, and it has replaced other variants of concern that were circulating. You remember Alpha, Beta, Gamma, Delta. We do think that those variants of concern may be still circulating at very, very low levels, but Omicron is dominant amongst the sequences that are shared publicly on platforms like GISAID. I should say thank you to GISAID as well for housing more than 11 million sequences so far. We are looking at two additional sublineages, which we've talked about previously, the BA4 and BA5. To date, I hope my data sitting in front of me is from today. I think it is. Less than 2,000 sequences of BA.4 are available from 30 countries, so that's still quite low level. And for BA.5, we have about 1,400 sequences available from 26 countries. So it's increasing in number, but it's still at quite low levels. South Africa, which has amazing researchers across the country, are utilizing their surveillance systems in populations and communities as well as in hospitals to help us track this. And it appears that their peak of BA.4 and BA.5 has in fact peaked and is going down, but their hospitalizations have remained quite low, and that's a good sign because we were worried about a potential change in severity, which we are not seeing with BA4, BA5. But as I said, we just don't know what the next variant of concern will bring us. We have several different scenarios that we're working under, whether or not we will have a change in severity, more severe or less severe, or whether or not we will have more immune escape, which means our vaccines may not be as effective. But we have to plan for that. So who asked the question?
The question came from Sarah Spurling.
So Kasara, that's a great question, and I think we want the viewers out there to understand that there's so many people that are studying this and that are working with WHO and working with our partners so that we could track this in real time. But testing and sequencing remains critically important to maintain.
Thank you so much, Maria. You also mentioned self-tests and being available in some countries. They're a cheaper option, but they're not cheap enough. So here's a question from Minat Nijen. I'm sorry for pronunciation. The question is about equity and the lessons learned on equity and access to different tools from COVID-19.
Equity, it's at the foundation of what we are looking at. When we look at this response and we look at what needs to be done for COVID-19, to have a test available that isn't used, that isn't accessible, is a wasted test. So we've been working very hard through our regional offices, our country offices, through COVAX, to increase access, to increase affordability for tests, for therapeutics, and for vaccines. This remains at the heart of what we need to be able to do because it's unfair. It is unfair that countries don't have access. We will continue to address this.
Thank you, Maria. Before we close, I wanted to ask you what is the exit strategy, but we got a question from Amrender watching us on LinkedIn as well. Do you have any model plan when this pandemic will end?
Well, it's the virus is with us. You know, we've had a lot of conversations about when the public health emergency will end. As you know, as the World Health Organization, the Director General declares a public health emergency of international concern. We are also discussing the criteria for when that public health emergency of international concern is over. But that doesn't necessarily mean the pandemic itself will be over. And I know that sounds a little bit confusing. What we are trying to work towards this year is to end the emergency, to take the death and devastation of COVID-19 out of all countries, not just some countries. Many countries have announced that their emergency is over, but that the pandemic is not. And I think that's an important distinction. So we are hoping, and we are working very hard to end the emergency this year, which means that we will significantly reduce morbidity and mortality. We will not have 10,000 people die that we know about each week. That is far too high, and that is an unacceptable number when we can prevent that from happening. We may not be able to prevent all deaths. I mean, that would be incredibly difficult to do, but by far and large, we can really reduce these deaths by increasing vaccination coverage, making sure we have tests, and getting people into the clinical care pathway. The virus will be with us, though, and the virus will circulate, and it will become endemic. But that doesn't mean that it has to be circulating at such an intense level. It doesn't mean that we will still see huge hospitalizations and deaths. And so we will have to manage. I don't like to say living with COVID. I really don't like it. And I know what people mean by that. We need to live with it responsibly. And many are not living it with responsibly, because living with COVID does not mean we give up and there's nothing left to do. It means that we live with it responsibly, and we look at COVID-19 in an integrated way with other respiratory diseases. COVID-19 is not influenza. It's its own virus. And so we have to treat it with respect and with humility, but we can look at respiratory diseases in populations the same way, and we can make sure that we provide good care. The big wild card are the variants. So my hesitation in being able to say when it will be over for sure is because we just don't know how the virus will evolve. But I think viewers out there should know that this will end. The hard part of this will end, but we're not there yet. So do what you can. Live your lives. Know what your risk is where you live. Reduce your risk where you can. Live your lives. Be social. Get vaccinated. Support each other. Support science, please. And really be part of the solution.
Sorry, I got distracted by the noises around. Tried to signal that we are in the live program here. Thank you so much, Maria, and these were very good answers and reminders as well to our viewers on what each of us still can do to come to that exit strategy. And maybe last but not least, as there's very high interest in the outbreak of monkeypox, and you've done a conversation with other colleagues a couple of days ago, but you also mentioned there's a lot of knowledge every day that we find. So do you have any update on the epidemiological situation or on this outbreak that you could share with viewers today?
So I can give you a brief update because it is an evolving situation. And so as you know, countries have been detecting cases of monkeypox in countries that don't typically experience or haven't experienced monkeypox before. The latest information I have, we have about, my numbers will be wrong because the numbers are increasing as surveillance increases. So we have about 200 confirmed cases and more than 100 suspected cases, but we expect those numbers to go up. It's across more than 20 countries and in 4 WHO regions. We are asking countries to expand surveillance so that we are looking for cases of monkeypox, cases of rash, particularly in people who present at sexual health clinics or emergency departments, infectious disease clinics, primary care, dermatology, and consider monkeypox as a potential diagnosis. It doesn't mean that everyone with a rash will have monkeypox, but we need to raise awareness about what monkeypox is and isn't. And we need to ensure that countries have the capacities to test, that they provide the right information. Most of the cases that have been detected in non-endemic areas are among populations of men having sex with men that identify as men having sex with men, but it's not necessarily will be only exclusive to that group. So we had a live the other day where we were talking about this, and we want to make sure that we do not stigmatize anyone related to this. This is about raising awareness. This is not a sexually transmitted infection. We do know that monkeypox does transmit primarily from physical contact, skin to skin contact, and that includes sexual contact. But it isn't the same as COVID. It's not the same as COVID, and we're not seeing that type of expansion. While I am talking about monkeypox, I think we should also recognize that monkeypox is endemic in a number of countries in Africa, in West Africa, and in Central Africa. This virus has been circulating for decades, and very little attention has been paid to this, sadly. And there are hundreds, if not thousands, of cases that are occurring there. So what we need to do, as we talk about monkeypox, is we have to talk about monkeypox as a whole and what needs to be done in endemic countries as well as the non-endemic countries. We need to increase our understanding through research, through the advancements of diagnostics, through therapeutics and antivirals. So there are different situations that are happening. One, in endemic countries where this virus has been circulating for a while, and much more attention needs to be paid to that. But in the non-endemic countries, we have about 200 confirmed cases, about 100 suspect cases, and those will be on the low end. We expect more cases to be detected. We are asking countries to increase surveillance. We are asking countries to provide supported care and isolate confirmed patients, to carry out contact tracing, because we believe we can stop the onward spread. This is a containable situation. It will be difficult, but it's a containable situation in the non-endemic countries. But I have to say we have uncertainty because we're describing what we are seeing. And I think anything we've learned in COVID-19 is that we need to be humble to this and really just advance on the understanding. And if advice changes, we will change that advice, but we will explain why. So please, the same applies. Be kind to one another. Please. Do not spread misinformation. Do not amplify these negative messages. We are in this together, and we need to help each other. But it's not the same situation as COVID-19. We need to use tools and antivirals and vaccines rationally on a needs-based approach, but also with the principles of equity and fairness.
Thank you so much, Maria, and I thank to all our viewers for their questions and for watching us today. As Maria said at the beginning, next Tuesday, 4 p.m., we will be together with Dr. Mike Ryan and Maria again, and we will provide more updates on discussions and decisions made in this World Health Assembly. Goodbye.